Hey everyone, in today's video I'm going to be walking you through a real patient case study from my office. Today we're looking at a 52-year-old woman that has both Meniere's disease and Hashimoto's, and her chief complaints are essentially bilateral hearing loss, so bad that she has to wear hearing aids, as well as bilateral tinnitus. Now she also has ear fullness in both ears and pressure in both ears. And what we're going to do through this case study is walk you through the history, how I worked the patient up, like what kind of diagnostics did we do, why did we do them, what was the treatment like, and what was her response. So if you have either Hashimoto's or Meniere's disease or both, I think you're going to find today's video very helpful because I'm going to show you what is possible with someone that has tinnitus and hearing loss. So let's get into it. All right, so if we look at her history, around 2014, she began experiencing itching and burning palms and hands. And ultimately what that led to was a diagnosis of Hashimoto's because they detected high thyroid antibodies and they prescribed a levothyroxine. So that's a pretty standard sort of treatment. Now, I will point out that it usually takes about 7 to 10 years to get diagnosed with Hashimoto's. So if she kind of fits that mold, she's probably been walking around with Hashimoto's since around 2007 or 2008. Now, a couple of years after she was diagnosed with Hashimoto's, hypothyroidism, and given the levothyroxine, in December of that year, the TPO antibodies were 561. Previously, they'd been 215. Now, I do want to point out that when people start comparing, historical levels of antibodies, like, hey, here they are now, and here's what they were before, you got to be a little careful about that because unless you're using the exact same lab that use the exact same biochemical method, you cannot compare the numbers, okay? It doesn't work like that. So we'll just assume that hers were done all at the same lab. Now her thyroid globulin antibodies were 13, they were previously 9. And at that time she began taking some essential oils that had frankincense, boswellia, and she stopped taking the levothyroxine. Now, maybe that was a good idea, maybe that was a bad idea, we don't know. But from about December 2016 to March 2022, when the antibodies were measured, and she didn't have those to show me, but she's telling me, the antibody levels seem to decline. Well, that sounds good, right? Now, is that the only thing that matters? No, because antibody levels fluctuate. And yes, we do want them to be as low as we can get them, but the level of those antibodies does not match up with how well you feel or how well you're doing. We still want them low because if they're too high, there's a bigger chance of cross-reaction, meaning those thyroid antibodies can attach to other things in your body and direct your immune system to attack those other things. So you end up with additional autoimmune problems. So antibody levels going down, we like that, but we don't know if that matches up with her overall doing better. So again, was the same assay used? We don't know. But the TPO antibodies were 36, thyroid globulin 7.1. Now that is substantially different, right? So maybe she was doing a good thing. I mean, boswellia is basically anti-inflammatory, so was frankincense, so maybe that was a good thing. But in August 2019, she began experiencing some rotational vertigo. And a month later, her right ear symptoms began with tinnitus. So she's having some high-pitched noises. And a few days later, after this initial ear symptoms, she had another episode of vertigo, which took a few days to resolve. Now, when you're getting ear fullness and getting vertigo, that's probably going to get diagnosed as Meniere's disease at some point. And a couple of years later, on January 4th, 2021, she had 2 episodes of vertigo, and had left ear symptoms. So now we have not just one ear, but the other ear, bilateral symptoms like that. That immediately makes me think for sure it's probably going to be an immune system related cause behind these symptoms. Years ago, people used to say that, Meniere's can't be autoimmune unless it's both ears. And really, as you guys know if you watch my channel, that's kind of really outdated thinking. Anybody who thinks that now, I think, is not really up to date. I can tell you that in my practice, the people that make it to me that have Meniere's, almost all of them have something going on with their immune system that ends up being the problem. Now, we'll find out if that's going on with her case. But I'm saying if I look at this and I hear rotational vertigo, and I have ear symptoms, that's probably Meniere's or something like it. And then I get it in both ears, that's probably the immune system that's doing that. I think it's probably the immune system in most cases, actually. All right. But about 2 weeks later, she was diagnosed with Meniere's disease and prescribed a low-sodium diet. Now, a low-sodium diet can be effective, but it's not necessarily going to be the only thing that works. Unfortunately, most Meniere's patients, when they're diagnosed, if this is explained to them at all, they're just told, hey, take a diuretic or do a low-sodium diet. Well, why do that? Well, I have some other videos, especially on how sodium triggers Meniere's episodes, Meniere's attacks, But basically, sodium beyond a certain threshold in itself is inflammatory. But also, sodium beyond a certain threshold will bring water with it. And of course, in Meniere's, you have what's called hydrops, which is essentially swelling or fluid accumulation in your inner ear. Now, you can have more what we call endolymphatic hydrops, or you can have more cochlear hydrops. Endolymphatic hydrops, that basically just means you have a lot of vestibular symptoms like vertigo, dizziness, and you may have some hearing loss or tinnitus. If you really don't have any vestibular symptoms like hearing loss, if you don't have vestibular symptoms like, vertigo or dizziness, but you just mainly have the hearing symptoms and hearing loss, that tends to be called cochlear hydrops. It doesn't matter that much to me in terms of what I'm going to do to treat it. I'm just letting you know that there is a little bit of a variety in the names that it gets given to it. But a low sodium diet is appropriate for sure. Now, in May 2021, which is a few months after her diagnosis, she returned from a vacation and her tinnitus had increased greatly. Now, we don't know why. We don't know if it's because she went on an airplane, if it's because she ate something that she shouldn't have, but the tinnitus had increased quite a bit. Now, 2 months after that, the hearing loss was noted. Like before she had tinnitus, now she's got hearing loss. And she reduced her sodium even further, because she may not have done it that much to begin with. It's like once things got bad, she was like, okay, well, maybe I'll reduce my sodium to around 1,000 to 1,500 milligrams per day, which is, not that much sodium, but it is something that is usually kind of a first-line recommendation. And it can be helpful, but it's usually not curative, right? It's usually not a long-term stabilizer. All right. Now, in late July 2021, she had an allergy testing, and that was negative. A couple months after that, she was taking HCTZ, which is a diuretic, prednisone, that's a steroid, dexamethasone, which is a steroid, and betahistine. Now, I've made another video on betahistine, and I'll link to it here in the video, but it's not that effective for most people that have Meniere. I mean, that's been my experience. It can be a little bit, but for most people, it just doesn't do much, and it's really not prescribed by hardly anybody here in America anymore because there's just not that good evidence that it actually does much. Now, 2 years later, she was taking something called famciclovir. Now, that is an antiviral agent. She thought maybe that helped for a while. Now, why would she take an antiviral medication? Well, there is a little school of thought out here in the Meniere's world that, all Meniere's patients have some sort of inner ear virus. I don't think that's true. I don't think that's accurate at all. Could some people have an inner ear virus? Sure. I think what people that believe that are kind of missing is that it's an inflammatory response. And the patients that I've seen, and of course I have a little bit of a selection bias, the people I've seen that have been taking valciclovir or famciclovir for Meniere's hasn't really done much. Meaning when they come off of it, they don't feel any worse. And they didn't feel any better. So anyway, she was just looking for some things to try to help. So, her doctors were trying to help her out. All right. Now, again, in September 2023, this is a couple months before I first saw her, she was vacationing in Europe and had worsening of her left ear symptoms. And then when she came back, she would say, hey, you know what? You have bilateral hydrops, meaning you got it in both ears. And it's probably more cochlear, as we'll find out, because her main symptoms are hearing loss and tinnitus. Now, she tried steroids again, no real change. Now, you might think, well, steroids are like an immune system suppressant. If she took those and it didn't help, that must mean that her immune system's not the problem. And that's not true. Yes, steroids are a way to try to calm down the immune system, but not the only way. They're not the only tool, but they is the only tool that 99.9% of ENTs have, is steroids. They are not going to do what you and I are going to talk about in this case here. That's just not what they do. That's not their training. That's not in their toolbox. So she did try the steroids. It didn't help, but that doesn't mean it's not an immune system problem. She tried an antihistamine, over-the-counter loratadine. Maybe that helped somewhat, but the positive effects seemed to fade. All right, so family history. Her mom's got migraines, her dad has epilepsy, sister's got hypertension and high cholesterol, but no like autoimmune diseases that we know of. Does that mean that it's not an immune system cause in this lady's case? No, not at all. Now her diet is unrestricted, but she has begun, as a lot of people do, they try to eliminate gluten and dairy. Now she's currently taking, in terms of supplements and medication, she's taking noni juice, which is kind of antioxidant, vitamin D, and a glucose control supplement. And that's pretty much it. Now, I'm not worried about any of that stuff because sometimes people will be coming in and they'll be taking things that I look at and go, you know what, that might be bad for you based on your immunophenotype. And we don't know what your immunophenotype is yet, so it's risky to take that. But none of that stuff she's taking there, I don't find that very troublesome. And of course, she took steroids about 2 weeks before she saw me. Now that's going to put a little wrinkle in some of the testing I would love to be able to do on her, but let's just see what we find out. All right, so what do we know so far? Well, we know that she has Meniere's, and it's more of the cochlear hydrops. Yeah, she had a little rotational vertigo several years ago, but mainly what she's had is hearing loss and tinnitus, and we call that cochlear. Now, it's in both ears, and we also know she has Hashimoto's. Now, I have a lot of videos talking about Hashimoto's relationship to vestibular problems, Hashimoto's relationship to things like benign paroxysmal positional vertigo. Hashimoto's is the most common organ-specific autoimmune disease. 9 out of 10 people that have hypothyroidism have Hashimoto's, but not all of them. Like I just had a guy yesterday I was doing a follow-up with, and he clearly has hypothyroidism, but he definitely doesn't have Hashimoto's. So not everybody, but most people. And Hashimoto's is an autoimmune condition, and those are inflammatory, right? So she has Hashimoto's and then develops these Meniere's type symptoms. I'm going to assume until further notice that this is going to be some kind of an immune system related Meniere's case. All right. So odds are that her Meniere's is immune mediated, probably inflammatory. Now, the problem is I really shouldn't do multiple tissue antibody testing. I don't know if you guys have seen me talk about that before, but it's a way of finding out what other tissues is her immune system attacking. Now, I already know at base that she's got Hashimoto. She's got an autoimmune condition. But I'd like to see what else is going on, because depending on what tissues are being attacked, that can tell me what foods she ought to be able to, she ought to avoid. But we can't really do that because we got to wait about 60 days after steroids to do that multiple tissue antibody test. And really, as I was telling her, you know, we probably shouldn't do this lymphocyte MAP, this immunophenotyping test, so close to the steroids. But, you know, if you want to spend the money on it, we can do it, but we really ought to wait 60 days. Well, she didn't want to do it. She really wanted to do the test. She didn't want to wait. She wanted to do the test. So fingers crossed that we get something that's usable. Or what we can do is say to ourselves, okay, well, whatever this immunophenotyping test looks like, it probably would be worse if we waited a couple weeks, because she has it's so close to the steroid dose, and steroids are trying to depress the immune system, right? They're trying to be anti-inflammatory. Let's see what we got. So what can I do? Well, I can do some regular blood work, and I can do the lymphocyte map, because she and I talked about it, and we're willing to walk in and do it. All right, so diagnostics, regular blood work, we talked about that. All right, so this is just some of the more relevant things from her blood work test, her regular blood work. Now, I say regular blood work because this is not like exotic, it's not sexy, but it's still got to be done, because there are things that you can find in here that can be compounding, confounding, complicating factors. They can be effects of the Hashimoto's, they can be causes of different things. So you just got to do it. So what you see here at the top is we see this thing called methylmalonic acid, and it says 240. Now, what is that? Methylmalonic acid is the best test to look at your B12 levels. I know that sounds weird, because if you've ever looked at blood work before, there's a test that says vitamin B12. That is not a good test for B12 levels, really. And there's some technical things in there that I won't bore you with. A better test is the methylmalonic acid. Now, its levels are inversely proportional to your B12 levels, meaning the higher your methylmalonic acid is, the lower your B12 is. Now, you can see that the lab here gives a range of up to 318 as being okay. For my purposes, she's in an area that's not great. It's not outside the lab range, and I'm not going to say she's B12 deficient, but I think she needs B12. Now, interestingly, B12 is anti-inflammatory. I don't know if you guys know that. B12 also can help with different types of nerve damage. So there's a possibility that this has something to do with her symptoms, or it may not. It just may be a separate health thing that needs to be addressed. Now, the next thing I'll show you here is this, her thyroid panel. Now, the TSH 6.34, is that high? Yeah, that is high. But if you look at her total T4 and her free T4, which I kind of messed up the box here, her free T4, that's all normal. So if the TSH is high, but the thyroid quantities are normal, and she has these Hashimoto's antibodies, what do you call that? Well, that is called subclinical Hashimoto's. There's a spectrum. I've got different videos on that. I don't know if I'll be able to link to it or not, but over here on the left, you have what's called euthyroid Hashimoto's. And that means you've got the antibodies that are elevated, but the TSH is normal and the free T4 is normal. Well, that's not her. The next stage is what she has, and that's subclinical Hashimoto's hypothyroidism. And that means she has the antibodies, the TSH is elevated, and the free T4 is normal. That's called subclinical. It's kind of confusing terminology. Now, should she be taking thyroid medication? Well, people can debate that. There's certainly some endocrinologists that would go ahead and give her thyroid medication, and some wouldn't. It just there's kind of a little bit of an art to that. But we do know that the TSH is elevating, and it's attempting to elevate to get her to make enough hormones. And right now it's working. However, if she gets much higher than that, she's probably going to get prescribed levothyroxine by somebody. So this is what we got here. We know that her B12 is too low based on the methylmalonic acid. We know that she has subclinical Hashimoto's. Well, does that mean the Hashimoto's is not a problem? No, because all you have to have is the antibodies for the Hashimoto's to be a problem. That's all you have to have that lets you know the immune system is a problem. There's been studies to show that all you got to have is the antibodies for things to go wrong. Now, we also know that the TSH is elevated, so we know that the Hashimoto's has been around for a while. Now, the other bit of blood work that we're going to look at here, this first thing here is her ferritin. Now, what's that? Well, ferritin is the best test of your iron. Again, a little confusing because you may have seen on blood work a test that says iron, right? Well, that test that says iron, that only reflects 1% of your body's iron, so not that helpful. Ferritin reflects 22% of your body's iron, so that's really what you want to look at. And 16 is not a good range. I'm not sure if I cut off the range, but the range in most labs is like 16 to 120 for women. She's at the very bottom of the reference range, and that's not good. That reference range is way too wide. Typically, we want to see a ferritin level in a premenopausal woman of at least 50. If they're postmenopausal, somewhere close to 100. So what does that have to do with anything? Well, a low ferritin certainly can cause different problems with energy. That's not really her concern. But it is more, I think, indicating that she may have a problem absorbing iron, okay, in her small intestine. That could be due to the inflammation from the Hashimoto's. There could be some sort of malabsorption thing happening. But 16 on a ferritin, not good, and it needs to be fixed. What about her folic acid or folate? Well, here you go, 11.9. They say, hey, if it's above 5.4, that's normal. Yeah, but it's still not good. A much better level of that would be somewhere around 14, 15. So research has been done that shows if your folic acid is around 10, that by itself is enough to cause neuropsychological problems like mood alterations and that kind of stuff. Why? Because folic acid is really important for making neurotransmitters. Again, in her case, she doesn't really have like depression or mood stuff, but we've got a ferritin that's too low, a folate that's too low, a B12 that's too low. So what gives? That all may be just, malnutrition, but it all could be a malabsorption problem. What would cause that? Well, we can go down the rabbit hole. I don't want to get too far, but the number one thing that would be linking all that together would be some kind of gluten sensitivity, maybe celiac disease, doesn't have to be celiac, okay? So that's what we're pulling from all these things, but that's got to get corrected as well. So we know that she's iron deficient and her folic acid is too low. Now this is the lymphocyte MAP, or lymphocyte immunophenotyping. So again, phenotype just means what something looks like. So immunophenotype means what does her immune system look like? And the thing about this test, what's so cool about it is her diagnosis can't predict what this is going to look like. It just doesn't work. Her symptoms can't predict what this is going to look like. When you do this test, what you're finding out, I tell people it's kind of like getting your immune system fingerprinted, right? Think about it like this, like you and I all have the same anatomical body parts, but we all have our own individual fingerprints, right? So you can't predict what my fingerprint's going to look like by knowing that I have 2 arms and 2 legs, right? You have to actually take my fingerprint. And we want to actually fingerprint her immune system to find out how we can best treat her flavor of Hashimoto's and Meniere's, okay? So if you'll notice at the top, her white blood cell count is low. Her lymphocytes, which is, okay, so it goes white blood cell count is the umbrella term. Under that, the next umbrella is lymphocytes. And then under that lymphocyte umbrella, we've got T cells and B cells and natural killer cells. The point is, you'll see that her white blood cell count is low. So her lymphocytes are 1,400, which is really too low. That needs to be more like 2,500. So we already know that her immune system is a little bit squashed. That's probably from the steroids, right? Considering that, what else do we see here? Well, you can plainly see that these T helper 1 cells, the total amount is high and the percent is high. And that makes this T helper 1, T helper 2 teeter-totter ratio abnormal. Well, where do you see that? Well, you see that in all kinds of autoimmune problems. But the thing is, we couldn't have predicted that that's what hers was going to look like. But now that I know that, I can do things to be anti-inflammatory and immune system regulatory, focusing on that, right? Focusing on this, not focusing on something else that she doesn't have, not focusing on boosting her immune system. That would be a mistake, all right? Okay, and then down here, there's some natural killer cell elevations. That might mean that she has a little bit of a post-infectious thing going on. You can't really say because of the white blood cell count being low and the recent steroid exposure, but typically, if someone's natural killer cell counts are high and their lymphocyte percent is up. They probably have an infection, but so we're not quite sure about that. But what I am really pretty sure about is this right here, right? This Th1, Th2 imbalance. Now keep in mind, this would probably look worse if we waited 2 months. So what are we going to do? So again, post-infectious, maybe. But the Th1 is definitely too high, and we need to work on that. And again, we wouldn't have known that unless we did the test in order to find out. All right, so what's the treatment plan going to be for her? Well, we're going to fix that B12, ferritin, and folic acid problem. We're going to maybe refer her out for thyroid hormones. I've told her, hey, look, you have subclinical Hashimoto's now. By my estimation, you probably don't need thyroid hormones, but run it by your GP or someone and see what they think. We are going to put on a short-term anti-inflammatory repair diet. I'm not going to go through what that is because this is the part of the video where people get a little bit frustrated because they want to know exactly what I did for her so that they can treat themselves with that. And you should not do that because this treatment is based for her. So I'm not going to go through all the individual pieces that we did because I don't want you treating yourself because you shouldn't do that. But we are going to use what we're going to call it an anti-inflammatory immune system regulatory supplement protocol, and we're going to see what happens. So she's doing this diet, she's doing the anti-inflammatory supplement protocol. What happens after 30 days? So after 30 days, she says, definitely been a change in the tinnitus. Okay, there's definitely been a change in the tinnitus. And what she means is that the noise level of the tinnitus, and if you have tinnitus, you know what she's talking about. I have tinnitus, I can hear it right now. It is lower and less noticeable, so it's not, the volume is decreased, which is good. So having some change in 30 days is a great sign, a very good sign. It's less severe. Okay, cool. Now she said her left ear is better than the right ear, but it does alternate day to day according to which ear is better, right? So it's a dynamic situation. So this is a good positive result. Is it 100% placebo? I mean, you could make that argument, but I'm going to base it on face value and say, hey, if she's telling me the tinnitus is lower, great, okay? Let's just see if it continues that way over time because placebo responses tend to kind of wash out. So we're going to see what happens. And me talking about placebo responses and washout is, I don't get excited when someone gets better after 30 days. I'm happy, but I'm not like, yes, I'm a wizard, I figured it out. We want to see her get better and stay better over time, right? That's when I start to get excited and happy. So let's see if that happens. Now, she thinks there's also been an improvement in the hearing loss. When she's at home, she doesn't wear her hearing aids. She wears those at work. And she can hear herself at home, and she can hear her husband better than she could before. Now, that's positive, right? Now, you would think, and I'm telling you, most ENTs are going to tell her you're not ever going to get your hearing loss back, but maybe she is. Now, the good thing is she's seeing her ENT in a couple of weeks after this appointment to get a follow-up hearing test to confirm if that's what's happening or not. So we're going to find out if that happened. All right. So after that 30 days, this is roughly like 45 days, she gets the hearing test done. Well, excuse me, back up. So the treatment plan is after 30 days, we're going to continue doing what we're doing, right? We are going to recheck the methylmalonic acid, the ferritin, the folic acid, and the TSH, because we do want to find out if we are doing what we think we're doing with those numbers, right? We're going to continue that diet, but I am going to let her trial adding back one item. Now, I'm not going to go through what all that means, but I don't do food sensitivity testing because it's a waste of time for a variety of reasons. I have done hundreds of them in the past. All you got to do is a little research, and you'll find out that there really isn't any basis for food sensitivity testing, like IgG sensitivity testing. It's not what you think it is. It's not what the labs are telling you is. We'll talk about it some other time. But what you can do is this, where I can add a food back, and we can monitor after she's avoided it for a while and monitor her response. So she's going to do that with one food because she's feeling better. She doesn't want to potentially flare something up. She's just going to try one thing. All right. And we're going to continue that anti-inflammatory immune system regulatory protocol. Now, she gets a recheck of the methylmalonic acid and the ferritin and the folate, right? So that's the original values right there. And so after those roughly 60 days, we can see really clearly that the see that the methylmalonic acid right here is now 161, and that's better, remember, because methylmalonic acid levels are inversely proportional to the B12. So the lower methylmalonic acid now means more B12. Her ferritin's gone from a 16 to a 29, which is actually not bad. Don't think that's bad. Getting from 16 to 29 is no joke, and she's doing that. And there's a special way you have to take iron to make that happen, and a lot of people don't know that. And then her folate is now over 24. Now, is that bad? No. But we know that she's absorbing these things, which is a great sign. If she wasn't absorbing them, we'd have to do things differently, but she is. Now, the one thing I don't like is that her TSH, is essentially unchanged. In fact, it went up by 0.05 of a point. Now, what does that mean? Well, it just means that it just didn't change much, right? So what are we going to do? Well, she still might need to talk to her GP and follow that, because she didn't do it the last time I recommended, and find out if they want to go ahead and give her replacement hormones. Okay, now, this, I believe, is the hearing test results. So this is her hearing test from November of 2023. And we're not going to go through this in large part just because it's probably too much to show you guys. But see this right here said recognition. So in November, she only had 92% recognition at 80 dBs, like that's the volume. And then the left ear, she had 96, a little bit better at 80 dB. Now, after 60 days of treatment, she got that hearing test retested, right? So what does it look like now after doing our treatment plan? Okay. Well, this is what it is. This is what it was on February 27, 2024. Now you can see really clearly, she's now at 100% in both ears. So she had an 8% increase in the right ear and a 4% increase in the left ear. She's now at 100% in both ears, which is fantastic, right? That is a really good response. And what does that tell us? Well, it tells us that what we're doing has to be what's behind that, right? That's not just some placebo response, right? So we like that. All right. Now, she did send me an email, and her language is a little over the top, but she said, "Good morning, Dr. Clark is my savior. And I knew it when I watched his videos on YouTube. I said to myself, this guy is knowledgeable." So basically what she's saying, and this is what I told you, that there was a big improvement on the right side. The left side still shows hydrops. Now, there's a electrococleogram I didn't show you, but basically it still shows hydrops on the left. But the ENT said there's a small hole from the injections they had in November, and that might cause the results to be a little bit skewed. But there's some hearing improvement as well. And she's going to have that done again in 4 months. So this is good, right? We can all agree that's good. So here's a lady that's having hearing loss, tinnitus, and after 60 days, not only has she had her own perception of the tinnitus changing and her hearing loss perception is getting better, we have some objective evidence that, yeah, you can hear better. You can definitely hear speech better. But we're not done. Okay, so what's our treatment plan going to be after we know that she's doing well? We're going to change things? Well, she still might have to get thyroid hormones. I'm going to let her add back one additional food item just to kind of make life a little bit easier. We don't have to move very fast with that. And we're going to continue that protocol, right? So after 90 days, 3 months of treatment, she says, hey, I'd like to add back tomatoes, but I'm going to wait because she's had so much improvement. She doesn't want to introduce anything that might mess that up. Now, what does she mean? Well, when you avoid foods and add them back, it's possible that one of the things you add back, you might have a reaction to. And in her case, that reaction is probably going to be inflammatory and could easily manifest in those ears and could cause the tinnitus to get worse or the hearing loss to get worse. But she doesn't want to do that. She's willing to play it safe. All right. But she did follow up with her primary care doctor finally, who retested her TSH, and her TSH was normal. Okay. So you have to remember that thyroid antibody levels fluctuate. TSH levels don't fluctuate as much as antibodies do. So when the TSH goes from 6 down into 3, that's a good sign. That could mean that we're getting control of that destructive Hashimoto's process. Because what happens in Hashimoto's is it destroys your ability to make thyroid hormones, and eventually your TSH has to go up because there's a negative feedback. So when the TSH is going down and all of our symptoms are getting better, it could mean that we are improving that at a really, really profound level. Now, as far as the tinnitus, 90 days in, she says, good days, bad days. She wonders if it might not correlate with an increase in hot flashes that she's been having because she's perimenopausal. She's having 4 to 5 major hot flashes per day. Now, is that reasonable? Yeah, that definitely could be connected. A hot flash is I'm not going to call it an inflammatory event, but it's basically what you call a big vasomotor event, right? You get a big fluctuation, a big pooling of blood at the surface. But those changes in hormone levels, the changes in hormone levels is what might be the problem. Not the hot flash itself, but the changes in the hormones that are producing that, right? Because you know what happens when you go to perimenopause? You're getting fluctuations but dropping levels overall. So what we're going to do is we're going to deal with that. Now, she did say, hey, the hearing that I told you about, this is still going. Like, it's still stable. I'm maintaining it. That's good. I'm getting excited by that. You guys probably tell I'm getting excited by it. All right, so after 90 days, we're going to add some botanical support for her ability to make her hormones, and some receptor response. So sometimes you can call these phytoestrogens, phytoprogestogens. I'm not going to tell you exactly what we use because it differs from person to person, but I picked out some things that I thought would be appropriate for her case. And our question is going to be, if we keep the hot flashes, if we minimize those, if those get better, means the hormone fluctuations are less, does that correlate with an improvement in the tinnitus? So that's what we're going to find out. So we're going to continue the other anti-inflammatory immune regulatory support. We're going to continue the diet that she's currently on, and she's added a couple foods back at this point. Now after 4 months, or what is that? 4 months. Try to do the math. After 4 months, she reports back and says, hey, the hot flashes are better and the tinnitus is better. In fact, she says the tinnitus is about 70% improved versus what it was before we started doing anything. That's major, right? That's a major improvement in intensity, how much she notices it. This is very, very, very good. So we know that there must have been some interaction between those fluctuating hormone levels and the tinnitus and the mechanism that was provoking it. Now, she did say she felt a little bit off and she felt like she needed an anti-inflammatory boost. And I got a little nervous when she told me that. But on her own, what she decided to do was just bump up the dosage of a couple things I had already given her. I was afraid that she'd gone out and like bought something off the internet, which could have been catastrophic. But anyway, she just decided to take more of the couple things that we were taking, which I said, okay, well, that's fine. You picked the right stuff. And then she said about 2 days later, she felt so much better, right? She was kind of feeling kind of crappy overall. She upped the dose, kind of a little first aid boost. And within 2 days, she was feeling significantly better. In fact, after doing that, she said she has felt better in the last few days than she has in 2 years with her right ear. And the best she's felt in 6 or 7 months with her left ear. So we know, the message is, we know that her immune system is related to her tinnitus and her hearing loss and her Meniere's, right? We just know that, right? We know that from her response. Now, I should say 120 days. Her treatment plan, we're going to continue the hormone support, not giving her hormones, continuing some things that are not hormones, but help her respond better to the hormones she does make. And we're going to continue the rest of the things that we were doing. Now, she has introduced at this point potatoes and kidney beans, no problem, okay? And she's going to want to try tomatoes and rice, all right? So let's see what happens. So now we're 6 months into treatment, and she sends me this email. She said, hey, I am great. I tried rice, but I think it gives me more belching, so I'm going to stay away from it. Tomatoes are good, fantastic. Now, this is the part I really like, okay? Now, she does have an ENT appointment for the repeat hearing test, and I probably should have waited to do this video, but maybe I'll post an update when we get that. But she says, look, the tinnitus is down, the hearing's better. This is awesome. This is like the real world impact of having some things get better. Last night, I was going to tell my husband to lower the TV, but then I said, no, don't do it, just enjoy it. Meaning, it's been years since she thought the TV was too loud, right? It's been years since she thought the TV was too loud. This morning, I was able to have a short conversation with a colleague without her hearing aids, and they were like 13 feet away. And so she says those little things make me happy, and they make me very happy. This is the kind of stuff that we're looking for. Not 30 days in, not 60 days in. 6 months after starting treatment, she's having real world changes, right? Imagine that, right? You had to wear hearing aids to hear anyone at work, and then she's able to have a conversation with someone 13 feet away without the hearing aids. The TV finally seems too loud. These are great things. I mean, when I read this, I chuckled and I laughed. You guys can tell that I love it. And this is the kind of thing that makes me so happy, does my heart good. And I do these case studies for you guys, not to say, oh, look at me, you know. I'm doing it to let you know that there is hope, like legitimate hope. Does this process work for everyone? No, of course not, right? Does it work for a lot of people? Absolutely. But it's not the same for every person, right? The workup we do, the testing we do, I know what tests to order, how to interpret them, but really it's about making sure we understand what is your particular flavor of this, right? Her flavor is the one that we just showed you. The next person that has the exact same symptoms may have a different flavor, may need different treatment, even though the immune system is probably involved. So anyway, I hope you guys found that helpful. This is the kind of things that make me really, really happy. It's why I keep doing what I do, because able to make changes like this that people call little, but you and I both know they're really big. They're really huge. So anyway, I'll see you guys next time. Have a good one. Bye-bye.